Welcome back to Cath Outreach. My name's Scott. This week we're going to talk about temporary pacemakers. So here are two examples of temporary pacemaker controllers. They vary in vintage in these two, and there's others out there that are even older than these that are still in service, still passing tests. But these are two from Medtronic, and the one on the left here is a single chamber pacemaker or a single channel. It can take one lead, so you can put that lead in whichever chamber of the heart you want, right atrium or right ventricle. But from a cath lab standpoint, I've never seen that used other than ventricle. Then the one on the right is actually a dual channel, and it actually has ability to have atrial and ventricular pacing coming out of the top of that. So what about mode selection? Mode selection tells the pacemaker how to function. And it's very important that you understand this. On the single chamber, a single channel pacemaker, that's not quite as important. But when you have a dual channel one, even if you're going to use it as just a single channel in the ventricle, you still have to understand what that means to make sure you're getting the response that you want. The acronym PSA, or the abbreviation PSA, like a public service announcement, that's what I always remember. It's pace, sense, and the activity in response to what it senses. So A is atria, V is ventricle, D is dual, meaning it could do both of those functions. I is inhibit. It means if it senses something that will inhibit the pacemaker from firing, it'll just reset its timer. And then O is off. We can just turn that whole function off. Lead location is an important part. Remember, the single channel I've only seen ever used in the ventricle. I guess you could use it in the atria if you needed to, but I've only ever seen it used in the ventricle. Because in the cath lab, what you're trying to do is stabilize somebody who's in a third-degree heart block, so that until you find a reversible cause, and if you can't, they get a permanent pacemaker. You may use it as prophylactically with somebody who's dependent on a pacemaker, so that while you're doing a battery change or a pocket revision, you've got extra wires there to be able to pace instantly if you needed it. Sometimes certain procedures can cause heart rate changes, and you can protect the patient this way. In the OR, that dual channel one, they actually may put atrial and ventricular epicardial leads on, so you'd have the full functionality of that pacemaker. So how do we program these? Well, first off, we want to find the threshold to make sure we're in a good part of the heart and we have good control. We want to set the sensitivity, and then finally the rate. So setting the threshold is the minimum milliamp setting that the pacemaker actually causes the heart to beat. Remember, there is electrical and mechanical capture as a difference. And when you talk about transcutaneous pacing, you're looking for that electrical capture, and then you want to make sure you have mechanical capture. It's still a good idea to make sure you have mechanical capture with this, but most of the time with these settings here, you have the mechanical, you're just using the electrical to dial everything in. But still confirm that there's an actual pulse with what's going on. Inspect to make sure you get what you expect. So set the rate above what the patient is. These things will inhibit if it senses a patient's rate. So if you set the pacer at 70 and their heart rate's at 80, then the pacemaker is never going to be needed because that rate is the bottom lower limit for their heart rate. So set the rate above it so it will cause the pacemaker to pace, and we know that we're in control. Then you want to steadily reduce your output, the milliamps, down. You most start at 10, or say you started at 10, that should be adequate to get capture. But just slowly, steadily walk your numbers down, calling them out to the physician as you're setting that. And then what you want to do is if you lose capture at all, you want it to be less than 1 millivolt. That means you're in a good area of the heart, you have good capture. If you never get capture, then no matter how high you go up, you're not making good contact, or you're making good contact with a scar or some type of damaged area of the heart. So if you lose your capture below 1, that means you got plenty of room for a good safety margin, and you can dial it up to 10 or whatever output you want. Just make sure it's at a safe level, well above the threshold. So when it comes to sensitivity, you can just kind of dial it in the middle there, and that'll probably be okay. But understanding why the number is picked, what actually is the best number for that, is a much safer way. And requires more knowledge and demonstrates your skill in what you're doing here. A properly set sensitivity will see the R waves. If this is a ventricular lead here, it'll see the R waves, but it'll ignore the smaller waveforms. If it senses everything, then that's called oversensing. And every time it senses something, it's going to reset its timer. Remember that all this thing does is reset a timer every time it senses something or it paces. So it sets a timer. It knows how many milliseconds it needs to wait. If it doesn't see a heartbeat up from the patient, it'll pace and then it'll reset its timer and look again. Well, if you take a undersensing, that means our fence, and think about your sensitivity as a fence. How high is this fence is how high the R wave has to jump up to be visible. So a properly set fence, properly set sensitivity will see the R waves, but nothing else. If you're undersensing, that means your sensitivity is turned way up, and even beautiful QRSs are not visible to this. And in fact, that's what asynchronous is. Asynchronous just runs this threshold, or runs this fence all the way up to where there's nothing that could meet that amount of energy, and this thing will just pace all the time. Oversensing means we're resetting our clock every time we see a P wave, a T wave. We can dial it down low enough to where any baseline activity is visible, and that resets the timer. So we don't want that. If it's just artifact, we don't want that to interfere with what the pacemaker is doing. If it sees any little bump as a intrinsic heart rate, then it's never going to pace. So properly set sensitivity is very important. So how do we set this sensitivity? Well, the first thing you want to do is set your intrinsic rate less than the patient's rate, at least by 10. I think this gives you a little safety margin where you're not going to interfere or walk over the patient, and you'll be able to see this pace light come on here in just a moment. You want to run your outputs all the way down, so if you do get capture, you're not competing with their intrinsic rhythm, because all we're trying to do is work on sensitivity at this. We've already set our threshold. We know what we're going to dial it back up to, but we can dial this down. Then you want to increase your sensitivity, raising the level of that fence until sense turns off. So every time it sees their heart rate, we should have a sense light flash. When we raise that fence up high enough, then it can no longer see it, and the sense turns off, and the pace will start flashing. We've set our rate lower, and we've set their output all the way down, so we don't have to worry about us doing anything to their heart rate right now. Now remember this, and then you want to set the sensitivity back halfway down. So if you lost sensitivity, say around 6, then you can dial it back down to 3 millivolts, and you know you've got a 2-to-1 safety margin for it to be able to see those R waves, but nothing else. So when it comes to rate, now we're going to set our rate. Remember, this is the lower limit. So the patient's, their heart rate can go as high as it wants to, and you want to set it at a clinically appropriate rate. And what that means is if this just needs to be a backup, then a heart rate of 40, you'll know when it kicks in. 50 or 60, if they need that. If it's somebody who had been in AFib for a long time, had been very tachycardic for a long time, and now we're actually, they're in complete heart block, maybe a higher rate their body is more used to. So you just want a clinically appropriate rate. And how does it know this timer that it resets? Well, it uses cycle length. If you take 60,000 and divide that by a heart rate, then you'll get a cycle length. If you take 60,000 divided by the cycle length, you'll find out what their heart rate is. And that's electrophysiology lab terminology, but that's kind of the milliseconds this thing is using. If you have a heart rate of 60, then your milliseconds in between your R waves, your cycle length is 1,000 milliseconds. So if we have a heart rate set to 60, this thing is going to start its timer, and if there's not a heartbeat in 1,000 milliseconds, this pacemaker will fire itself. If it oversenses and it senses anything, then it's going to reset that timer, and that's why that sensitivity setting is very important. So if you set your rate at 50, then that has a cycle length of 1,200 milliseconds. So if there's not a heartbeat in 1,200 milliseconds, the pacemaker will step in. And there's also Like if you get 70, 70 into 60,000 is right about 857 to be exact. So that's the cycle length, that's the timer length that it will watch and then pace if nothing else happens. And then there are some special uses for pacemakers. We use this during TAVR, transcatheter aortic valve replacement in the cath lab. You're blowing that balloon up, stretching out that new aortic valve in the outflow of the left ventricle. You don't want that left ventricle to fully contract and try to push against a closed valve. You're going to cause a lot of damage to that left ventricle. But one of the things you'll do with this is actually pace at a rate of 160. A lot of times, it's a very common number, but pace at a rate of 160 that knocks out the cardiac output. And then once the balloon is down, you can turn the pacer off. This little area here allows you to set your pacer rates and sensitivity normal, like we've already done, but have this special area where you can actually turn it on, set it to the rate that you want. While you're holding the hold to deliver button, it's going to pace at that rate. As soon as you let go, everything reverts to the other settings. The nice thing about that is you can get what's called overdrive suppression. And the longer you've paced very fast, when you come off, their SA node may not be awake. They may not come back very quickly. So you by doing it this way, you already have a rate ready to protect that patient if necessary. All right, that's it on temporary pacers. I hope that was helpful, and we'll see you next time.